We've made it to pregnancy physiology. So the next 2 weeks, we'll be going over pregnancy. This is Katrina Wu, and I'm really excited to start to get into this content because this really is the majority of the work that we're doing as midwives. You can see in the picture of this woman here, it's clear that her uterus has grown. She's pregnant, and yet you can't tell from the outside just how many body systems are impacted by pregnancy, which is essentially every body system. So that's what we'll be starting to get into today and over the next couple weeks. And I just wanted to start with this quote from Proverbs 31 on the virtuous woman, and I think it's especially fitting for thinking about pregnancy. She is clothed in strength and dignity, and she laughs without fear of the future. All right, let's get into it. So for this week, we'll talk about changes in the uterus, breasts, the cardiovascular system, and blood. And then we'll end with immunology. And then next week, we'll cover the rest of the systems. The uterus undergoes significant growth in pregnancy. And it starts out as hyperplasia, meaning that the cells multiply. You're getting more and more uterine cells. And then it's hypertrophy, meaning those cells get bigger. So initially, a lot more uterine cells and then larger uterine cells. There's about a 20-fold increase in weight alone in the uterus during pregnancy, and that's not including what's inside the uterus. So irrespective of amniotic fluid, the baby, placenta, just the uterus goes from about 2 grams to 2 pounds in pregnancy. And estrogen is responsible for uterine growth. So similar to the menstrual cycle, estrogen is what's causing the uterine cells to get bigger. And then towards the end of term, the uterus will thin out. And that's why pregnant people are able to feel their babies moving even from the outside. So the uterus is really thin, and then abdominal muscles and then skin. You're able to feel baby moving even through that because the uterus has become so thin. And then progesterone's main role in the context of pregnancy and the uterus is to maintain uterine quiescence, or keeping it quiet and not contracting. And so progesterone is going to stay high throughout pregnancy. And then towards the very end of pregnancy, it starts to dip off and decrease. And that will help the uterus become more receptive and responsive to oxytocin in preparation for labor. So in pre-pregnancy and early pregnancy, the uterus is considered a pelvic organ. And then as it grows in pregnancy, by 12 weeks, we would consider it to be an abdominal organ. And we also say that the uterus has a right obliquity or dextroversion, and this just means that the uterus is tilted more towards the right side. We don't really know why this is, but the main thought is that it might just have to do with how the colon is positioned. And interestingly enough, if a woman does have a UTI in pregnancy and it travels up to her kidneys, it's more likely to affect her right side due to that dextroversion. So pyelonephritis risk in pregnancy, that risk is higher on the right side. And then after the birth, it takes about 6 weeks for that uterus to shrink back down to being back in her pelvis and no longer an abdominal organ, which is pretty incredible that can take place in just 6 weeks when it took us 9 months to get that large. So breasts undergo significant growth in pregnancy and are typically one of the very first signs that a woman would experience when pregnant. So in first prenatal visits, I would say sore or tender breasts, having missed a period, and feeling really tired would be the top 3 things that I hear. And this tenderness or tingling, heaviness is experienced by 4 weeks. And so from here on out, when we talk about weeks, we're going to be using it in reference to their last menstrual period. So in the context of embryonic growth, oftentimes we're talking about, at day 8, they're implanting. And that's really going back to fertilization. But from here on out, when we're talking about weeks, it's gestational weeks, which goes back to the last period. So 4 weeks gestation for breast tenderness would be the same as thinking about, 2 weeks in from ovulation. So those first 8 weeks especially, there's significant vascular engorgement and rapid enlargement. And that's due to both estrogen and progesterone. Estrogen is increasing ductal growth significantly, and then alveolar hypertrophy is because of progesterone's impact. Nipples enlarge and become more everted. And the areola is going to enlarge and darken, and Montgomery glands will become more prominent and visible as well. There's a French OB named Michel Audant, and he likes to refer to this as the chocolate mountain. So we know that newborns tend to just see in more black and white. And so having the areola become larger and darker gives them like a chocolate mountain target, something to aim for. With all this rapid change, it is so important that women have a good supportive bra. Back pain is so prevalent in pregnancy, and so we don't want something like wearing the wrong size bra to be a contributing factor. And a lot of women want to hold off and wait until they're going to buy their nursing bras, but really encouraging them to make sure that they've got a good supportive bra for every step of the way. And if they're going in to get a new one, I say make sure you're getting good, thick, supportive straps, and then also that they're starting on the tightest buckle, because their thorax is going to continue to expand in pregnancy. And then lastly, some women will notice colostrum in pregnancy, and it's fine if they don't. The hormones in the placenta suppress lactation, and so it's giving birth to the placenta and the hormone withdrawal that follows that really enables people's milk to come in. So sometimes that can make primips anxious if they haven't noticed anything in pregnancy, but it's really just fine. So nothing to worry about. But that said, some women will notice colostrum even as early as 14 weeks in pregnancy. And if they were already breastfeeding, say a toddler or a younger child, they can continue to nurse throughout pregnancy as well. They might notice a little bit of a dip in their production. Okay, so that wraps up breasts, significant growth, some changes there. And it really is, it's up to 1 pound in each breast alone. So it is significant growth. So moving along, there's a lot of extra fluid on board in pregnancy, and that increases from about 6.5 to 8.5 liters. So that includes maternal blood volume, amniotic fluid, any fluids associated with the fetus or placenta, and that's extravascular as well as intracellular fluid for the woman as well. So that's primarily due to the kidneys. They're absorbing more sodium and water's following in the nephron tubules. So the kidneys are responsible. There's also an increase in thirst. So between the increase in thirst and the decrease in excretion from the kidneys, the result is more fluid. So the result then is there's an increase in maternal weight gain, hemodilution, which we'll get into a little bit more here, and increased cardiac output. Your Blackburn text has more details on that if you'd like to read more about it. Having this extra fluid is protective and heading into labor, since most women will lose a fair bit in the 3rd and 4th stage of labor. And particularly if somebody does have heavy bleeding postpartum, this helps them achieve homeostasis more easily. This rights itself pretty quickly after the birth. Those first couple days involve a lot of sweating and a lot of peeing off all that extra fluid, and then that brings them back to balance. And then just going back to early pregnancy then, by the 5th week, thirst and urine output are both increasing, but then by the 8th week, ADH and vasopressin increase, and the body develops kind of a new set of blood osmolarity. And so thirst may decrease, but they're holding more water. So beyond needing it in the event of like a postpartum hemorrhage, why do we want more blood and more fluids on board? So there's an increase in blood demand, and this extra fluid serves us in a few different ways that affect multiple systems. So having these extra fluids means that we have an increase in gas exchange in the lungs, because we're needing to breathe for both the mom as well as the baby. The increased metabolism by both the fetus as well as the pregnant person means that there's an increased excretion of waste. And so higher blood flow to the kidneys is needed in order to excrete the excess waste. We also need more blood flow to promote increase in growth for the uterus, fetus, and placenta. And then bearing in mind that while there's no mixing, the placenta does carry a lot of that maternal blood. So needing extra fluids and extra blood on board in order to both promote the growth of these areas and fill up this space, such as in the placenta. That increased metabolism also means there's an increase in heat production, which leads to peripheral vasodilation. And so we need higher blood flow to the skin to accommodate that. So all of these factors ultimately show that there's a need for an increased amount of blood in the system. So now let's continue talking about the cardiovascular system. Let's start with the heart. So initially there's a mechanical displacement of the heart. So it moves up and to the left a little bit, rotating just a little bit. And then we also see hypertrophy. Estrogen stimulates cardiac muscle hypertrophy, particularly in the left ventricle, which allows for an increase in filling. Progesterone's effect on calming and quieting muscle also helps contribute to that increase in left ventricular filling. Heart sounds are louder in pregnancy with an exaggerated split. So you might hear a little bit more of a pause between the S1 and S2 when you're listening. Systolic murmurs are really common in pregnancy. Just thinking about that extra blood on board makes it harder for valve edges to touch. So to hear a systolic murmur would be considered normal, and especially if it's stage 1, really nothing to worry about. If somebody already had a pre-existing condition with a murmur, that might be worth a cardiac consult in pregnancy, depending on what you're hearing and the severity of their pre-existing condition. But you can certainly bring a cardiologist into the care if needed. There can also be an increase in arrhythmias that would be common and generally wouldn't be concerning. Cardiac output increases by about 30 to 50% in pregnancy. And as a reminder, cardiac output is a combination of both heart rate and stroke volume. So it can increase by 50% already by 8 weeks, so pretty fast. And then it peaks at around 25 to 30 weeks. Initially, that change is due to a stroke volume increase, and then later it's due to a heart rate increase. So that means that initially it's because we just have such an increase in fluid on board, and then later our heart rate increases a little bit too. So cardiac output is dependent on maternal position. It's lowest in standing, sitting, and supine positions. So you hear about supine hypotensive syndrome, where a lot of women are nervous about laying on their back in pregnancy. And in general, if they're fine, their baby's probably fine too. So the concern is that if they're laying on their back, then it might be closing off the aorta and minimizing blood flow to the placenta. But if women aren't beginning to feel lightheaded or nauseous or sick and needing to roll over, probably that means that they're getting adequate blood flow and their baby is too. Now, in labor, if a baby's looking stressed, then yes, we're going to move. But it's unlikely to be as concerning as most women feel it is in pregnancy. That said, a lot of women do feel uncomfortable on their backs. So definitely listening to their bodies and moving accordingly is an important piece of that. And you'll notice, though, that standing and sitting are also on that list of having lower cardiac output. And there's actually at least one study I've seen where women who were on their feet a lot for work actually had lower birth weights for their babies than women in other positions. And so the researchers weren't sure, is this due to the position that they were in throughout the day? Is it due potentially to poverty and other effects that poverty can have that also led women to be in positions where they were needing to stand all day? So we don't really know, but kind of an interesting finding. And then definitely the best position for cardiac output is going to be a mom laying on her side with her knees kind of tucked up. So blood volume is going to increase until about 30 weeks, after which point it plateaus. The increase in blood volume correlates positively with both fetal weight as well as multiple gestations. So if somebody is carrying more than one baby, then they'll have an increase in blood volume accordingly. So while the overall blood volume increases, it doesn't increase at the same ratio in terms of the components of the blood volume. So plasma in relation to red blood cells is going to increase more, leading to more of a hemodiluted state. So in this image here, you can see that top line that's blue, that shows the blood volume increase overall. And then the yellow line just under it is showing specifically the plasma increase. And then that bottom red line is the red blood cell increase. This really stresses the importance of iron supplementation in pregnancy. Everybody's going to have a little bit in their prenatal vitamins, but making sure that if they are on the lower side, that we're encouraging supplementation. So you can see here that without any supplementation, red blood cell volume increases by about 18% in pregnancy, whereas with supplementation, it increases by about 30%. Fatigue is common in pregnancy, so this is one way that we can help to support that. And then the other piece too is thinking about the birth. We don't know how much blood we're going to lose, and if we're heading into a labor already low, how much longer is it going to take her to feel good and strong again after the birth? And does she have that buffer if her bleeding is heavy in labor? So hemoglobin in pregnancy initially is around 12, and then it dips mid-pregnancy in the second trimester to be about 11.5, and then pops up to about 12 by birth. So we expect to have a bit of a dip in the middle of pregnancy. Typically, practices will do a full complete blood count or CBC in their first trimester at their first prenatal visit, and then we'll recheck when we're doing labs for gestational diabetes. So that's usually around 24 to 28 weeks. Usually the recheck would just be the hemoglobin and not a full CBC. And then as long as those first two are normal, then that's usually the last time it'll be checked before the birth. The technical criteria for anemia in pregnancy is different than for non-pregnant people. So it would be 11, 10.5, and 11 as being the formal cutoffs for anemia. Though practices may vary a little bit in how they choose to treat it, so they may very well go ahead and recommend iron supplementation sooner than those cutoff points. And it's not uncommon to also check for ferritin level or their stored iron, in addition to like a hemoglobin hematocrit. I do think it's worth noting that being a little bit hemodiluted does help with the placenta for transferring substances. So the fact that it is a little bit hemodiluted makes that transfer easier. Erythropoietin is going to rise near term. That's what stimulates red blood cell production. So that's helpful in preparation for potential blood loss at birth, and is also partially what's responsible for that hemoglobin rising again towards the end. So we have a dip in pregnancy and it rises again. So erythropoietin released by the kidneys is helpful and responsible for that. And then our reticulocyte count in general is going to be elevated in pregnancy. Those are the immature red blood cells. The heart rate does increase by about 10 to 20 beats per minute by 32 weeks. So that'll help with maintaining that increase in cardiac output. And then blood pressure tends to decrease mid-pregnancy and then return to baseline at term. So that follows a similar trend as our hemoglobin. And then lastly, we're going to see a little bit of a decrease in systemic vascular resistance. So veins are basically dilating to hold extra blood. This dilation occurs in part due to progesterone. Remember, it helps to relax smooth muscle, so that includes within the lining of veins. And then endothelial prostacyclins and relaxant factors such as nitric oxide also play a role as well. So all of them are working to kind of dilate veins to hold extra blood, which will have an impact on some of our side effects or common discomforts for pregnancy. So that decrease in systemic vascular resistance would be the cause for things like varicose veins or hemorrhoids. So there are some hematologic changes to the uterine blood flow as well. So changes to the uterine spiral arteries, which we already talked about. So they're dilated in order to be able to give good perfusion to the placenta. But of note, they're not responsive to the influence of the autonomic nervous system. So usually if your body's in stress, then it intentionally sends more blood to some areas and less blood to areas like your intestines or your uterus. That's not important if you're running from a bear. But in the context of pregnancy, it's not under the influence of the autonomic nervous system, so that regardless of what the mother or pregnant person is experiencing, there will continue to be good blood flow to the placenta. That's not to say that chronic stress couldn't have an impact, but at least in like specific situations where, you kind of go into overdrive, there's going to continue to be good perfusion to the placenta and thus to the fetus. So there's also an increase in renal blood flow to the kidneys. So there's an increase in glomerular filtration rate by 40 to 50% in order to address all the increased waste that needs to be excreted from both the mom and the baby. And then skin perfusion is also much higher. So an increase in skin temp and clammy hands, mucous membranes, congestion. And we'll touch on skin changes too, but a lot of that is due to the increase in blood perfusion. So estrogen and progesterone are bringing more blood to the surface of the skin, and then those valves are also leakier. So we'll get into dermatologic changes next week. So what do all these hematologic changes mean for pregnant people? Well, I just wanted to put in another plug. If somebody's coming into pregnancy with an already established cardiac defect, these are pretty big changes. So a big change in blood volume, the heart is growing and turning, that increase in volume, and then postpartum having that rapid postpartum decrease in volume, all can take a pretty big toll on somebody if they've already got something going on with their heart. So wanting to watch those patients more closely and seeing how they're doing through those changes and possibly bringing in cardiology too if needed. And then edema and varicose veins. So let's just get into those a little bit more closely here. So edema, we know that we need more fluid in pregnancy in order to have an increased blood volume, etc. So there is more sodium retention at the level of the kidneys, which draws in more fluid. And then there's a high level of vascular permeability, meaning that fluid within the blood vessels can more easily leak out into the extravascular spaces. So between progesterone making vessels leakier and just having a lot more fluid on board, it's easier for fluid to leak out. And then as the uterus grows, it puts pressure on those veins that are trying to get blood back to the heart. So then you get some backflow there. So especially for dependent edema, that's going to be more common as the uterus grows. And in turn, we'll see more nocturia where people need to use the restroom at night because they lay down, and then that shift with their belly makes it easier, and gravity makes it easier for all that blood to finally get back to the heart and for lymph to return. And so as that extra fluid makes its way back into the blood vessels and then to the kidneys, we pee off some of that extra fluid overnight that's been kind of building up in their feet and legs during the day. So with varicose veins, we've got those two primary factors that influence it, one being our enlarging uterus that makes it hard for venous return, and that increased venous pressure influences it. And then on the other side, we've got progesterone causing smooth muscle relaxation and then vasodilation, so making those vessels wider. So between being wider and that increase in venous pressure, it's hard to keep blood only moving in one direction. So in our left image here, you can see that blood is going up, and then as it goes up and through that vein, those two valves are able to meet again to close off any backflow. And then on the right, where we have varicose veins, that increased blood makes it harder. So as blood moves up, the two valves have a hard time meeting because of the increase in blood and because of the vasodilation from progesterone. Those valves have a hard time meeting, and so some of the blood can pull back where it came from. So you kind of have a multi-directional issue there. So varicose veins are present in around 40% of pregnancies, so they're pretty common. And most common places to find them would be in like the legs, as well as vulvar varicosities. So running through the labia, those can be especially tender, painful. And then hemorrhoids are essentially varicose veins that are in rectal veins. So that vein is pooching out and then extending beyond the rectum. So that's a hemorrhoid. They will regress after pregnancy's finished. However, that damage is still there. So if they have subsequent pregnancies, it'll probably be the same degree, if not worse, and progress in future pregnancies. Compression stockings can be really helpful for just helping those valves have some support to be able to meet more easily. And then putting them on first thing in the day before blood is starting to pool can help. And there's also belts that women can wear for vulvar varicosities that can be really helpful too in just providing some more pressure. They typically have a strap that runs around the lower abdomen as well as between the woman's legs. And it just provides upper pressure similar to a compression stocking. Varicose veins can run in family, so there is a familial tendency there that has to do with valve incompetence. Okay, I think that's enough on varicose veins.